This presentation is on ECG interpretation. All ECG graphs have an X and Y axis. The X-axis is seen along the bottom of the graph and the Y-axis is what is seen along the side. On the ECG recording, every small square is 1 millimeter in length and every large square is 5 small squares or 5 millimeters in length. On the ECG recording, there will be an isoelectric line. The deflections above and below the isoelectric line represent the depolarization and repolarization of the heart. The classic representation of the full heart cycle is the PQRST wave combination.
The rhythm strip represents voltage against time and allows the diagnosis of normal or abnormal heart rhythms or arrhythmias. The common 12-lead ECG has 10 seconds worth of a rhythm strip. Typically, lead 2 is used for the assessment of heart rhythms, but V1 is a good indicator of atrial rhythms. Atrial rhythms may interfere with the morphologies of the QRS complex, ST segment, and T waves. Ventricular rhythms may produce retrograde P waves and interfere with ST segments and T waves. So conventionally, when performing interpretation of a rhythm strip, you must examine atrial activity, examine the ventricular activity, identify if the conduction is A to V or V to A, look for interference patterns, name the rhythm by what is happening and recognizing the rhythm strip pattern. There may be more than one type of rhythm on the rhythm strip.
There are a number of artifacts that may interfere with the rhythm strip and make interpretation difficult. Artifacts that need to be recognized and resolved are, for example, muscle tremors, baseline sway, and ASE interference.
To identify sinus rhythm, compare the shape of the heartbeat to the next and surrounding beats to note differences and recognize shape similarities and contrasts. Determine whether the atrial and ventricular rhythms are producing a normal deflection and ensure they aren't too fast, slow, missing, too many, or too few. Wave and complex basic interpretation includes checking that the P waves are upright, the same shape, and one per heartbeat. PR interval should be 3 to 5 small squares and repeated pattern. QRS complex should be a repeated pattern, regular rhythm, normal duration. ST segment should be flat on isoelectric line and T wave upright and rounded. Heart rate should be between 60 and 100 beats per minute. A higher heart rate would indicate tachycardia and a slower rate bradycardia. Interpretation of abnormalities. Sinus arrhythmia is the interval between each R wave and can vary greatly due to inspiratory heart rate being fast and expiratory heart rate being slower. This could be associated with young adults and athletes. This can be seen immediately post-exercise.
There are 4 main atrial arrhythmias: atrial ectopic, atrial tachycardia, atrial fibrillation, and atrial flutter. Atrial ectopic consists of unusual morphology of the P wave and could interfere with the T wave. The PR interval may be shorter, RR interval may vary, and heart rate may generally be faster than the rest of the rhythm due to short RR intervals. Atrial tachycardia is the unusual morphology of the P wave and may interfere with the T wave. The PR interval may be shorter and difficult to interpret, and the RR interval may be irregular. Heart rate is usually faster than 200 beats per minute. Atrial fibrillation is the unusual morphology of the P wave and may interfere with the T wave. The RR interval is generally irregular. Heart rate varies significantly. This abnormality may be associated with hormone disorders, medication toxicity, hypertension, and respiratory disorders. Atrial flutter is the unusual morphology of the P wave and may interfere with the QRS and T wave. This produces a sawtooth pattern and the RR interval is generally irregular. Heart rate varies significantly. As with atrial fibrillation, this is always abnormal and may be associated with hormonal disorders and hypertension.
There are 3 main ventricular rhythms. These are ventricular ectopic, ventricular tachycardia, and ventricular fibrillation. Ventricular ectopic includes hidden and missing P waves. It is necessary to check for retrogrades, AV dissociation, QRS prolonged duration, and widened morphology. There is a compensatory pause between the T wave and the P wave. The heart rate is generally faster than the rest of the rhythm. A frequency of more than 6 per minute classifies the abnormality. Ventricular tachycardia is when the P wave is missing or skipped. The QRS complex has a prolonged duration, PR interval is missing, and the RR interval is shortened. The heart rate is generally faster, and this can be associated with hypoxia, ischemia, and toxicity. Ventricular fibrillation generally shows no P wave. The QRS complex varies, mostly has a prolonged duration and a chaotic pattern. There is no PR interval, and the RR interval is short and irregular. The heart rate is fast and above 300 beats per minute.
Hypertrophy is the enlargement of the muscle and any cardiac chamber. However, enlargement of the left ventricle is most commonly seen. This can be due to heart failure, athletic hearts, and cardiomyopathy. It can be difficult to diagnose as the ECG signs and muscle size are not always the same. In sports people, it is commonly seen as an adaptation shown by an increased amplitude and slower beat. There are other extreme heart abnormalities. However, within a sports setting and generally fit and healthy individuals, such cases as heart block would not be so relevant. When using an ECG in any setting, it is important to understand the key components of the reading and have knowledge and recognition to identify characteristics of the common abnormalities and arrhythmias covered.